25% of the global population are hypertensive. Out of this 25%, 4% are children. The range is so, and in addition, 13 to 18% has your elevated BP. So thereby, measuring BP is essential. And also, a good amount of children has masked hypertension. So around 10% or so. They need to be addressed. So this is what I said earlier. This data, what this table says, that 13% of the children has hypertension, more than 13%. So thereby, the BP of the children should be measured. And small amount of full-term units, sick preterm, and has hypertension, 0.2 to 0.8 respectively. 10% of the adolescent children has hypertension. And the American data is your adult and children. The half of the hypertension USA went unrecognized, and 50%, only around half, another half has controlled BP. So in obesity, Bangladesh data is from our institute, 20% of the children in the city and 8% of the children in the village are overweight. Of them, 25% has hypertension. Why do you measure BP in children? Why didn't measure? It's not fair. We didn't measure. We went our time. We passed our time without seeing the BP of children. Your generation, next coming people, you should measure the BP of children. This is what the topics. So yeah, hypertension, basically adult hypertension, they can be traced back the 3 years and onwards. So to avoid the CV events and death, number one cause of death is hypertension and your cardiovascular mortality, MI, and then heart failure. So the kidney failure, they start from the 3 years and onwards. So BP of all the children above 3 years should be measured. Pediatricians, unfortunately, as I said earlier, we do not measure the BP most of the time. Only when it is evident clinically it matters to have nephrotic or this and that we do measure. When other instances we do not. This is not fair. So how do you measure the BP? We measure by NROids commonly. Your mercury free is the best. Mercury one is the best one. NROids are mercury, but because of the pollution, it is being banned. And now we measure the others, and the manual is not that accurate, but it is to be used in adjunct to with the NROid sphygmomanometer. Automated is nice. And then intra-arterial is more accurate, but it is invasive. Others, oscillometric, ambulatory blood pressure. These are the newer modality of measuring the BP, volume clamp, tonometry, for your photoplethysmography, etc. So oscillometric devices and the oscillatory devices, they need to be validated by for pediatric use. And these are the sites where that can be validated: British and the Irish Hypertension Society protocols, American protocol, as Hypertension Society, and then Canadian, and your STRIDE international website. One should validate these instruments. Unvalidated hypertension measurements can have again your additional hazard, and then not measuring standard BP. How to measure? I think Amina's videos have everything. So we'll keep it at the line at the end of the session, I think. Yeah. Is it here? Yeah. Yeah. So let us wait. So comfortable rest, 2 to 3 minutes, and your feet flat, uncrossed, BP less right side, because it is validated. It is in the right side. Yeah. And then upper arm should cover. It should be bare and loosely flare. Just 2 fingers can be inserted into it, and patient should not speak. Neither the physician nor the patient should speak while one record the BP, and electronic devices and other distractors should be away from the BP measuring side. And you to know these things, 80%, 100% of the length of the bladder should be covered, and the white should cover 40%, average 37 to 50% of the arm circumference, and 2-finger manipulation in between is nice. Manual BP, yeah. You raise the BP for 20 mercury column, or your the 30 to 40 to 20 to 30 millimeter mercury above your obliteration of your radial artery pulse and deflate it by 2 to 3 millimeter mercury per second and appear and then see when the first sound comes. You call it Korotkov 1, K1. Last sound is Korotkov 5. You take this record for the above 13 years mostly. But below 13 years, in good amount of children, you do have your less than your come sound is muffling, and then going to zero on 4, 3, 5 something. So take the muffling point, okay, 4 as a diastolic BP of children below 13 years. Infants is very difficult to measure. It's difficult, hard to measure the BP of children. So take time, have patience, repeated measuring, have patience. Do not forget that if you do not measure the right BP, you will be losing the child in the hypertensive, heart failure, and so forth. A crying and feeding child has higher BP, supine prone. It makes the difference. So make sure that patient has been fed and 1.5 hours prior to your BP record. Obtain 3 BP and take the last 2 BP your as an average. So these are the BP curves. Yeah, now I think Amina's video, Amina, I will be talking a little bit and she'll be showing how to see the BP. See what she does. So sorry for the net issue. So what I was telling you, the one third, two third, even 70% of the fast BP record may not remain valid, may not be true BP. It comes higher most of the time. Go for second reading and third reading. And 20% of the adult hypertension can be traced back from 3 years to onwards. Obesity and other primary essential hypertension producing elements contribute over here. So below 3 years, these are the children. You need to be measure the BP, prematurity, necrosis, sepsis, heart disease, congenital heart disease, recurrent UTI, kidney disease, and organ transplant, lupus and others. So and CNS issues, raised intracranial pressure, they need to be measured their BP because it's often high, and the low birth rate quite high in this country, 16%, 20% at times. And they have, you see this figure, 1.5 to 2 millimeter mercury, BP increment is seen when the 1 kg weight is less than the standard, 3 and beyond. So they have reduced nephron endowment. Again, so the BP you measure, you need to be confirmed by ambulatory blood pressure, 24 hours record at certain interval, 40 to 50 records, and so day and wake and time and sleep time. So these are the conditions where you need to do a BPM to confirm the measured BP even by three records. And clinic BP needs confirmation. Secondary hypertension, they have very often masked hypertension and chronic kidney disease. Yes, they do have masked coarctation factor, diabetic nephropathy, they have circadian variations, and obesity. Yes, they do have masked hypertension, thereby they need to be checked. And the obstructed sleep apnea, they do not have good sleep at night, they do not have dipping. Dipped and non-deepers has higher amount of CV events, thereby their blood pressure needs to be measured in ABPM, other syndromic and antihypertensive drug assessment, etc. They are looking catecholamine secreting events, sympathetic discharge that do have dipping. So if you do have the versatile BP, so they need the 24 hours picture, and thereby the measuring this dipping is essential. Non-deepers, dipping normally 10% because of the sympathetic discharge at night, it is 10% less. If they do not occur, this undiagnosed hypertension and undiagnosed hypertension will lead to your CKD, and because of the raised BP and also the CV events and their home BP can be an alternative to a BPM. We measure the daytime home BP. What it does, it measures the BP in the word. Not self measurement is not home BP. Home BP means take 3 to 10 readings, 7 readings in the daytime, and 3 to 7 days in a week. This is what this slide says. It says you take several days in a week. I said earlier, you do wake time, and then your rest and seated comfortably as and aware of your limit. It has also some limitations. So this is how the clinical practice guidelines of America, AAP, they have classified hypertension. You know these things. Any BP above 13 and beyond in our age, even to the end of life, more than 120 by 80 is hypertension. In children, and below it, it is normal BP, and 90 to 50. So you have elevated BP. So, and here it is 120 by 80. Stage 1 hypertension means 95 plus 11. And in the adolescents and the adult, it is 130 by 139 something, and 80 to 90. Stage 2 hypertension 95th and beyond, plus 12, beyond plus 12, or more than 140 by 90. What this slide tells you, European Society of Cardiology, they said 70 rather than 80. So this they have initially they had higher figures, 85, 90. But nowadays they say no, we have some amount of loss of life and then the mortality, morbidity as well. So they said it should be 70, not 80. That's the same. This is a BPM classification, reverse classification of BPM. They say 95th centile less, more than 95th centile. And then on the other side, in the extreme right hand, if you look at the slide, awake BP should be less than 125 by 75 millimeter of mercury in 24 hours record. And wake BP, yes, it is to be higher. How much higher? 125 by 80. And in sleep BP, 110 by 80. And And marked hypertension, you have naturally your lower BP in the office setting. And ambulatory, you have higher setting. These are the figures like the above figures 125, 75, 130, 80, and 110, 65. 24 hours, wake, and then sleep respectively. Could I make you understand? Figures are complicated, no? Oh, Sabrina, do you get me? What does it tells? What this slide says? Can you sum up these slides? One line. Yeah, yeah. No, it is the ambulatory BP. But who can tell better from this one? Delaware, I think you will be good. This, yeah, I think we, yeah. Don't let me talk, and then I will ask you again. Yeah. So what this slide says, if you look at the right side, the extreme right side, 24 hours BP, not 140, 180, 180, nothing, 130, nothing. It is much lower. Ambulatory BP much lower than the standard BP or the assumed measured AAP or the European guideline, ESPN. So less than 125, less than 75 is normal BP in ambulatory measurements, 24 hours. Do you get me now? So in the wet cell, it will be higher. How much higher? 130 by 80, right? And the sleep time, so 110 by 65 BPs. They are found to have no CB event, no cerebral event, no neural event. So thereby they are regarded as a safe event measured by the ambulatory BP. What is the idea of measuring ambulatory? Idea of ambulatory BP to have a safe BP.
আর ওই যে একটা ঘন একটা স্যালাইন দেই আমরা, ওটা কি দেওয়া হচ্ছে আজকে?
I think salam দিচ্ছ কোথায় দাঁড়াও so now it is solid, I think, audible.
Okay, sir, continue. Sir, continue.
Okay, my Mamun, thank you. So any BP, any severe, what is acute severe hypertension means in above 3 years, above 13 years, any BP more than 180, so the systolic and diastolic 120 is very severe hypertension. It can have organ damage, is life risking. So below 13, it is more than 30 millimeter mercury above the 90th percentile for the corresponding age, gender, and the height. So they need to be addressed because without measure, these children may have brain damage, cerebral infarction, hemorrhage, encephalopathy, left ventricular failure, pulmonary edema, and grade 4 and 5 retinopathy. So yeah, so this is the figure like more than 130, more than systolic, and then more than diastolic more than 80 is called elevated BP, and more than 180 and more than 120 systolic and diastolic respectively are called your acute or marked elevated BP. So if they do have organ damage, you call it emergency, hypertensive emergency. If they do not have it, you call it emergency. You have hypertensive urgency. Formerly, basically nowadays the urgency term is being replaced by asymptomatic markedly elevated BP. True. And rest on the other side, you may have asymptomatic elevated BP. So these children, they need to be addressed faster. Otherwise, they will cause a loss of life. These are the contributor factors why children do have this sort of raised BP all of a sudden. So unsafe BP 180, 120. Why this is that? This is uncontrolled. BP was not controlled prior hand. And there was biological factors like stress and other category events. And there are the overload issues like the sympathetic distress, fluid overload, the other issues, acute distress, pain, anxiety, that cause sympathetic distress. A lot of critical events that produce hypertension. And your BP, previous BP medication, there were some of the medication that can cause hypertension, like NSAID and your steroid and erythropoietin and other herbal medications. So previous BP was not well controlled, inappropriately controlled previous BP. It didn't do ABPM. As I said earlier, ABPM is a level. ABPM measures are the levels are a little bit lower than your traditional BP. So why this is measured the measures, because in the BP fluctuates. When it goes up, you have organ damage and death and morbidity, mortality. So thereby, keeping the issues earlier, ABPM features 125, 75, 65, sleep and wake, they're different. They're a little bit less than the standard or traditional. So sleep deprivation, stress, more screen time, these are the factors that give rise to someone shooting BP and can have organ damage. So how to address your BP, how to algorithm of the causes of hypertension. If you go by far algorithm, what this slide tells, it tells you the symptomatic BP, take your urgent measures. Asymptomatic, you take your weight. You go for ensure whether BP is really raised or not. So symptomatic, we always admit and give your urgent attention. As I said earlier, your emergency always IV and admit, and then in urgency also admit and take measures. And asymptomatic BP takes two measures, as I said earlier, still is elevated. You recheck BP and take a little bit more time. When it is symptomatic, you do not have enough time. Stage 1 hypertension, you do not have much time. Here, time is restricted, a little bit less, 1 to 3 weekly, and at the end of 3 months, you decide. These are the points where you have chronic hypertension, you have hypertension, primary hypertension, lower sort of lower grade hypertension. In upper grade hypertension, acute hypertension, you cannot do this practice business. You have to take measures on that day. So on the stage 2 and beyond, you check both the lanes, because a good amount of them have your uniovascular hypertension, your vasculitic hypertension. So they have to be addressed in that way. I am not going to read this slide in total. This is what this is: acute severe hypertension, organ damage, patient death. Take admit and IV antibiotic, IV antihypertensive. On the other side, you have a little bit of moderate, you have to wait moderate amount of time. You have a little bit less disease load. You can wait and make sure that BP you measured is normal. As I said earlier, 1/3, 2/3, and even 70%, the fast record may be fallacious. So let us see what are the causes of childhood hypertension. By far, the renal cause is the commonest. Around 1/3 to your 3/4 of the pediatric hypertension are renal and renovascular. By far, the commonest renal disease is the CKD. And then all sorts of GM, all hematuric symptoms, C2G, IgA vasculitis, and so forth. And then your uncommon elbow symptom, that to be renal hematuria, proteinuria, edema, nothing, azotemia, nothing, CKD, nothing. So hypertension can be only presentation. On the other side, this on the right side of the slide is a long list of diseases. I'm not going to read these things in total. Obstructive disease, cystic fibrosis, your ciliopathy, the infection, pyelonephritis, tumor, etc. They do have hypertension, maybe only presentation, maybe combination of the other features of the respective diseases. So by far, the commonest renal, followed by the basically currently it is primary hypertension, which is the second most in position. Around 20 to 30% of the children has. As I said earlier, 30% of the adolescents, 20% of the adolescents has hypertension. And your if you take the other data, you have around 20 to 30% of the children hypertension at least primary, and with that is you do not even reach any clue. Metabolic syndrome comprised of what? Obesity, hypertension, dyslipidemia, and diabetes mellitus. So renovascular is the fourth one, 5 to 10% of the renal pediatric hypertension, which usually goes unnoticed, unaddressed, untreated. So I'll be talking a little bit of these two, and then monogenic 1%. But you people who has to address this issue, because nobody else in this globe will be able to diagnose these entities. You should know the diagnosis. Thereby, I will be talking a little bit of this and that. Monogenic, these are the 6 or 7 monogenic hypertension. GRA or the global cortical imitable. Type 1, familial hypercholesterolemia. Type 2, type 3, 4, and apparent renal cortical excess. Gordon, Little, and cross. These few entities are thyroid, adrenal gland, cushion, hypercalciuria, acromegaly, etc. Cardiac coarctation of aorta and then aortic stenosis, PDA. You are acquainted with these things. I am not going to talk these things. And vasculitis, polyarteritis nodosa, lupus. These are not the today's topics, perhaps. So I will skip. Apart from the respiratory, chronic lung disease can have obstructive sleep apnea and chronic lung disease apnea. That can have hypertension. Pregnancy associated hypertension is quite common. 20% to 25% of the pregnant women are hypertensive. In fact, so this syndrome like hypertension exacerbated pregnancy, in genetically predisposed person called Jeller syndrome, preeclampsia, you are acquainted with this thing. Gestational hypertension, you are acquainted with these things, medications, illicit drugs, environment, the environmental pollution, what it does, it causes the sympathetic discharge, it causes the cadmium, mercury, their level is high, and the pollution is also contributes sound. It also inside the sympathetic discharge, catecholamic release, you have hypertension. And most worst part is that hypertension in those cases are not that detectable because it remains masked. So this is what Afros is interested to in showing the slide. She was asking me, please show my slide. Yeah, this is what I brought for you. It tells everything. In fact, it's a wonderful slide. It tells everything about hypertension. The left side, what you see, your right side, what you see, risk factors of hypertension. You know these things. I'm not going to talk. I'll talk a little bit. On the right side, human modifiable factors. On the left side, your right side, human modifiable factors. Food insecurity, low income. They have. So when someone says, yeah, next time, yeah, I don't have security of the food, I will eat more right now. This is another reason. The of low economy, the people has more hypertension. The previous idea was not true, and the non-modifiable factors, yeah, premature low birth weight, neonatal insult as I said earlier, and environmental factors, sound and pollution, as I said earlier. On the right side, what do you see? This what are the I'm not going to tell the clinical features of hypertension, you know these things, but these are the complications as I told earlier. Adult hypertension, I told earlier, 20% of the adult hypertension can be traced back from the 3 years onwards. So this is what then how they present. So you people, we people, the pediatric nephrology group, we need to address these things, resistant or refractory hypertension. Ultimately, good amount of hypertension in children, they will come to you after many hands, multiple referral and cross-referral failure, they will come to you. People should know how to handle these cases. First, define the resistant or refractory hypertension. Hypertension not able to control by 3 medications, including 1 diuretics. Or that means 4 or more drugs. Patient needs more than 4 drugs. So these are the causes: renovascular, renal, monogenic, and endocrine. I said earlier, in the 1/3 to 70% of the 80% of the pediatric hypertension are renal and renovascular. So these are the causes how a CKD patient became hypertensive. Already you know that 40% when stage 1 and 2, and 80% in stage 4 and 5 children are hypertensive. If I make a round figure like this, so about 20% may remain as without hypertension, and on the other side, in the earlier stage, 60% may remain without hypertension. So these are the factors contributing. Important of which are the RAS inhibition, RAS activation, your nitrous oxide reduction, and your endothelin 1. You have the vascular stiffness by calciphylaxis or atherosclerosis, and then you have endothelial dysfunction, and you have secondary hyperparathyroidism, and there are other factors also. your angiotensin, nothing too sympathetic overactivity, uric acid level, sodium, etc. So, and the other contributory factors. So, it's long list. I want to read this line. It's slide into two, but these are the common, even common mediators that give us the hypertension in children. This is a question frequently asked in exam. What are the why the CKD patient will be hypertensive? These are the clues to diagnose CKD. The anemia growth failure, they are frequently attributed to the malnutrition in this country. When along with anemia growth failure and your proteinuria hematuria, you have the hypertension, your diagnosis is then CKD, nothing else. So, and there you know the other features. I'm not going to tell about CKD features over here. How do you diagnose and screen out of CKD? There are three investigations. One, urinalysis, RBC, CAS, past cell, and then your proteinuria and cast, sedimenturia, whatever you call it. And you have creatinine and urea. You know the fallacy of the creatinine, plenty, 20 or more. So despite fallacy, if you combine the urinalysis data, the ultrasound, and your imaging abnormality, ultrasound saying this, ultrasound, say what this small kidney, CMD poor, CMD, corticomegaly differentiation poor, and then corticolecogenic increased. And you have tubulopathy features, you have obstructive features, you have hydronephrotic features. So by other imagings like your DTPA, DMSA, and so forth, your CT and MR urogram, you are certain to diagnose your three small investigations: urinary, ultrasound, and creatinine. This that can tell you screen almost certain 80% clarity about the CKD diagnosis. The neurovascular hypertension, the impaired blood flow to the name says narrow renal vessel. How much narrow? More than 60%. This is the clues. I am not doing the fibromuscular dysplasia, idiopathic fibromuscular dysplasia. By far, the commonest of neurovascular hypertension, around 1/3 to 1/4. And the syndromic neurofibromatosis, Williams syndrome, they said it is common, 5 to 10%. But unfortunately, could not diagnose the expensive vasculitis, lupus, and so forth. And the reports on data from the neighboring country and Japan says the KD, KD means Kawasaki disease is quite common. Takashi's arthritis is also common. Vascular malformation is umbilical catheterization, the neonatal period in this country is quite high. So they are important, and their rubella at times, transplant cases can have hypertension. How close to renal-vascular hypertension means when you suspect, when there is very high blood pressure, more than stage 2 and beyond, when you have your secondary organ damage because of high blood, high BP, and you have not been able to control it by two diabetes medications, and your vasculitis features, underlying cause features, and you have your BRUI, you frequently tell in exam, BRUI is found in only 10 to 30% cases. But this one is very important. This is your ultrasonography sonologically, one side kidney is smaller than the other side by 1 centimeter, more than 1 centimeter difference. Usually think of, yeah, it is possible by hypodysplasia and other means. But think of if you get these things with the hypertension, think one important differential over here is the renovascular hypertension. And this study says the incidental finding do not have any features in good amount of cases. How much? 50% or so. And the rest of this present, I'm not going to read this. That can come to hypertensive crisis, proteinuria hematuria, consequent to hypertension. Hypertensive patients can have proteinuria hematuria by hypertensive nephropathy. So, how to diagnose renovascular hypertension? There invariably has more renin and aldosterone increment. So thereby what the renin aldosterone do, they raises what they do. So sodium absorption. So sodium absorption has been taken out by the body homeostasis, so it remains normal. But potassium is eliminated by in exchange of sodium. Isn't it true? You get me, Robin? Get me? Yeah. So you have hypokalemia. What about the chloride? It goes down. Hypochloremia. And what about the sodium goes up? What about the alkali? Yeah, it will be alkalosis. Sodium is eliminated in exchange of your sodium is absorbed, potassium is eliminated. True. True. I think Aurangzeb will be the best person to talk. That's why I understood you know this part. Aurangzeb, বলেন তো কেন why the sodium is so your potassium will be low, the chloride bicarbonate will be low. Yeah, true. Work of the function of aldosterone is to absorb sodium. In doing so, it draws water also, thereby volume expansion, thereby hypertension. True. And in doing so, what it does, it eliminates the potassium, hypokalemia. So you have acidosis, you have alkalosis, bicarbonate will appear to be high. So so discrepancy of the kidney size, the leg discrepancy more than 1 centimeter, I said earlier, along with the if peak PSB, peak systolic volume velocity more than 3300, resistive index more than 80%. So, but this is not, so Doppler ultrasound is the answer to screening test for the uniovascular hypertension. Milan, what I say is clear. Okay, then be with us. So how to confirm uniovascular hypertension? I said screening test is the ultrasound. How to confirm always by the digital subtraction angioplasty, DSA, to catheterize him. If you see this block, what the Awad Tariq and the Tamina they do, when do you send this patient by Doppler? Yes, it is there. They also, sir, will do the same procedure in the same city. That is we wrote the series report from this university. So, and that it feels, and hypertension was really turned, that patient was asymptomatic and it's gone home. This Cox brother fellow, this and the Chittagong, the few Maruf's case or other one for Cox brother. So, what they do, the same sitting, they have to go for angioplasty. Could I make you understand? That, right. The same sitting. They put in catheter in the femoral artery when it passes to the narrowed part, CT angiography, and they go for angioplasty or a stand, whatever you call it. The same sitting, diagnostic and therapeutic, the same sitting. A patient became listen to patient, they became asymptomatic. They went from their maintaining. One is having small kidney for the narrowed, and the sclerosed kidney. That one has reduced GFR. He is maintaining with 1 hypertension. It is a success also, because if patient had 4 or 5, so I'll be talking later on about this part. I said already these things. When do you call renal artery stenosis or narrowed? More than 60% of the lumen is of plus collaterals. Yeah, when it is narrowed, you have development of the collaterals since birth. How do you treat endovascular hypertension? If I summarize this slide, what did how can you do not use every medication except ARB. Rarely you do use, most of the time you do not, because the renal artery is narrow. Already, if you put another agent who is also narrowed the renal artery, you will be doing worse. That's why ARB should be avoided. Other antihypertensive as you choose, and what the your right side of the slide says. So it's not being shared. It's all right. So right side, so you attempt, as I said earlier, you attempt the angioplasty and angiography and for angioplasty in the same sitting. If segmental block, you go for the segmental embolization. When your one side kidney is very small with GFR less than 10%, or on someone other author says less than 5%. The source of hypertension, remove that kidney perhaps. Because that kidney is the RAS and other mechanism that, as I said earlier, there are 15 or 20 mechanisms in this table. As you see, would you like to see to recapitulate these things? Yeah. These are the mechanisms in hypertension, in renal, in endovascular. You see 15 or 20. So start operating. Source of nuisance, hypertension in the endovascular. So remove that small kidney with minimum function less than 10%, 5%. So this is the nephrectomy. Unilateral, really you need to do it. So finally, your pharmacological treatment of the endovascular hypertension. As I said earlier, the RAS anti-RAS should not be used. Calcium channel blockers can be used. As I said, out of the calcium channel blockers, the non-pyridine dipyridine calcium blockers, have antiproteinuric effect. But this one, here the best drug is dipyridine, your calcium blockers, beta adrenergic agents without sympathetic activity means they are not super selective alpha adrenergic. Your MRF. So first line of choice is this calcium channel blocker, 1, 2, beta, and then alpha. True. Next one, not SNTRB. Good amount of time, most of the hypertension nowadays, you said better drug is the RAS, anti-RAS. The S inhibitor or ARB. But here, different picture. So these are the three choices. And mineralocorticoid receptor antagonist, we didn't talk about third and fourth line agents, and then thiazide, the last option. Look, there it is. I'll be talking a little bit of mechanism of action, and finally your selected cases angiography, angioplasty. A good amount of time, 50% cases, you manage the renovascular hypertension with medications. Rest 50% you do need surgery, angioplasty, and nephrectomy. These are the situations where you go for surgery. Mid-aortic syndrome. It's not always the renal artery which is stenosis or narrow. Good amount of time you have and the aorta and its branches narrow. So mid-aortic syndrome. Here you need to take measure of those sites. So do angioplasty and take measures on that sites, and the aorta and branches may be narrowed. Auto transplantation or sympathetic graft on those places, and sympathetic nerve denervation. Finally, 50% of the graft loss, 50% of the improved function is possible. So if I summarize the renovascular hypertension, 5 to 10% of the pediatric hypertension, renal and renovascular, they have very severe sort of hypertension, stage 2 and beyond. They do need more than three or more antihypertensive. They have organ damage. They have, they have the smaller kidney on one side, other kidney may be normal, more than 1 centimeter difference, and they are diagnosed by Doppler ultrasound screening test, and they are finally treated by angioplasty, and you're diagnosed by angiography and treated by angioplasty. 50%, 50% by medication. Best medication is the calcium channel blockers, beta blockers can be used, alpha blockers can be used. The MRA, mineralocorticoid receptor antagonist like spironolactone, epileron, they can be used. And their mechanism I will tell you later on. I have a few slides on this, and lastly may need the surgical intervention. Pardon? Other diets, yeah. They are also intact. Low dose equivalent tablet 50 milligram half BD. So now I will be talking a little bit about the primary hypertension. As I said earlier, this is the second most largest group in pediatric hypertension. When do your adolescents? I said earlier, 10% of the adolescents have hypertension. You measure the BP of adult, every adult who has 20% hypertension, 21% hypertension incidence. True. Then why don't we measure the children with BP incidence prevalence of 10%? Very sad. We go past our time without seeing it. We didn't do fair. It's not fair, but perhaps in our lifetime, in the one bad thing practice we show. But your time will be different. Hopefully, you won't do these things in the near future. So actually, 6 years and onwards. See I said earlier the 3 years. Then it is 6 years and onwards with the beginning of the predisposing events, operating all this and that of primary hypertension. You have elevated BP, and these are the features in the primary hypertension: obese child, physical activity less, psychomotor, the psychosocial impairment. They have families, the fathers, the whole parents, whole families obese, and they have familial hypercholesterolemia, and they have frequently obstructive sleep apnea and truncal obesity, acanthosis nigrans, and other features of the high obesity. So smoking and alcohol may be there, and close to primary hypertension. You take 2 to 3 days, same, nothing difference. And you take the ambulatory blood pressure. Very often they have marked hypertension. So marked hypertension means, what do you mean marked? Yeah. Hypertension recorded in clinic BP is low, and the home BP is actually high. So if you do not address this home BP, we will be missing the good amount of time, and the child has hypertension and have organ damage, chronic and acute organ dysfunction. Could I make you understand? So that BP, I said, it is to be taken by home BP measurements or ambulatory. As I told earlier, true. বোঝা গেছে কি গেল না? Yeah. Okay, fine. So this slide tells everything about that. I won't read these things and how they are. Secondary cause, you try to know the extent of secondary causes, as I said earlier, the way as a means of finding the secondary causes. I'll be talking a little bit about this later on. And so they have organ damage. So these are the investigations for the primary hypertension. They are obese people, which is the blood sugar, diabetes component of the
ভালো শোনা যাচ্ছে না তো।
So I think I'm audible. Shaila, do you hear me?
Sir, we can hear you.
Yeah, thank you, thank you. Yeah, I understood. Yeah, I'm audible. So I'm sorry for the net interaction and interruption, everything. Jasmine, শুনতে পাচ্ছেন আমাকে?
জি স্যার, শুনতে পাচ্ছি স্যার।
Thank you.
Sir, please continue. Yes,
Thank
sir.
you, Hamid. So this how this monogenic hypertension present with the early onset severe resistant hypertension. They have electrolyte abnormality. I'll be showing this slide, NAC-based abnormalities, and at times they have androgenic effects. So this table, let's take have a little bit attention. As I said earlier, your aldosterone synthesis defect in the beta 11 beta hydroxylate deficiency. You have glucocorticoid remediable as aldosteronism. That means aldosteronism and hypertension, which is relieved by steroid. Type 1. They have ectopic ACTH influence, genetic defect, all monogenic. What these names that suggest? You have gene defect mutation, single gene mutation, you have gene product, and you have death product influence the tubularity absorption of thereby you have hypertension. Absorption what? Most of the time you do have excess aldosterone and its brother like cortisol. Could I make you understand? Yeah. Praveen? Okay, fine. So let us have a little bit patience. I'll summarize this whole slide in few lines. So this one is what the first one is the FH1, familial hyperaldosteronism 1. 2, what does it tell? It says chloral channel coding gene is defective. You saw you see the name of the genes over there, and you have excess aldosterone production. Similar things with the 3 and 4. Potassium channel coding channel is defective, and calcium coding channel is defective by a defective mutation. Could I make you understand? All 4 will have hyperaldosteronism, and will have hypertension. Clear? So next is what I'm talking about a little bit. Jealous syndrome, I told you a little bit, receptor controlling gene is mutated. Thereby, it has excess aldosterone absorption. And what apparent cortical excess tells, here conversion of cortisol to cortisone is defective because of this 11 beta hydroxylase generation deficiency, controlled by, again, by bint of another mutation, controlling the 11 beta gene mutation. Thereby, they have more uncontrolled cortisol production. They cause hypertension. You know this. You see this slide. It's walking upon your collecting tract. Finally, a little bit of the Gordon on the your right upper side. You have Colin 3, KLH3, and WNK1 and 4 gene mutation. You have this NCC channel overactivation. You have increased sodium absorption. You have hypertension. Not aldosterone issue is there. And what the process syndrome says, do you see the gene over there, NHNR3Cl? Don't need to memorize these things. But what this syndrome is, process means mineral excess and the resistance. The receptor is there, but resistor is mutated, it's not working, it doesn't respond. So you have excess mineral activity, you have excess aldosterone activity, you have hypertension. Finally, Liddle syndrome, you know these things, ENaC activation, epithelial sodium channel activation. By dint of, again, it's beta and gamma subunit mutation. You have, again, with excess sodium and water absorption, you have hypertension. So these are the summaries of the monogenic hypertension. There are 8 or 9 types. And this is this table, what is, I don't know, I don't read this table in 2-2. The right side, your right side, on your left side, what do you see over here? Treatment. Physiological GRA type 1, you have excess cortisol secretion. Suppress those ACTs by dint of another steroid. That's why the name has come. Mineralocorticoid responsive your hypertension. You give steroid, this ACT production will be prohibited by feedback mechanism. Then you can use also mineralocorticoid receptor antagonist. As I said, you are also saying the spironolactone and eplerenone. You can use the ENaC blockers over here. ENaC blockers, epithelial sodium channel blockers. They are the amiloride and triamterene. Then other 2, family 3, from type 2, type 3, type 4, hydrochloride, hydrogen ion, chloride ion, and calcium channel defect respectively. You have to only hypertensive over here to treat these cases. Congenital hyperplasia, I won't tell these things in over here beyond this. So you know these things, 11, 3 varieties of CAS. One hypertensive, other one is virilizing, other one is salt losing. 2, 21, 11 beta, and then other one. So you have 21 beta with these issues. Here treatment is spironolactone again, and then because it is MRA, aldosterone antagonist. There are other things, AME, I told already. Gordon, yeah, this hydrochlorothiazide, same. That's it. I promised you I'll be talking a little bit of hydrochlorothiazide. How does it work? It works with the blocking the chloride co-transporter inhibitor. How it is antihypertensive? It inhibits the chloride in the CT and DCT. distal and collecting duct. And your little, again, you have this receptor blockers like amyloid, trampoline, which is what is amyloid kisher arongo, amyloid trampoline kisher blocker. Yeah, spectrum blocker. So it that channel. Or আসছেন তো একটুখানি ইয়ে হয়েছে আর কি ঠিক হয়ে যাবে be with us always and don't yeah. So এটা আমি বোধহয় বলতে চাচ্ছি না জেলার চিহ্ন সাপোর্টিং into potassium supplement good amount of time when you know you was telling them your woman was telling when the aldosterone is raised for good amount of time what the aldosteronism there's a term in the book window to hyperaldosteronism you said already hypokalemia hypochloremia and alkalosis but when it lasts longer you have hypokalemia. I think Momen is the best person. He told me that this is the mechanism like why do we get this hypo? So then you have hyperpotassiemia, you give potassium supplementation. But long term is the gelar. This is the adolescence case, female issues, pregnancy issues. So that again crosses you have this mineralocorticoid responsive. I owned it. This is not our topics today. So hydroxylosis pushing pheochromocytoma. You know how to diagnose, how to treat. How to diagnose pheochromocytoma? One urine. Yeah, BMA and then yeah. BMA and renal meningic acid and then other one then homogalenic acid HMA. HMA is said to be superior to BMA. In our time we did BMA. Now say they said the HMA other one is good. So combine this together two and then have CT scan and then features of the so renal secreting tumors, no, it's not our topic. So I'm skipping this part. Primary hyperparathyroidism, your topic is how to diagnose a primary hyperparathyroidism secretly. One, yeah, parathyroid gland, we have hormones, calcium, phosphate, vitamin D. What else? You diagnose adenoma and hyperplasia. How? Scintigraphy. Parathyroid scintigraphy. There's a name. And CT scan. Good amount of time. Parathyroid gland. It's not just in the tip of the thyroid gland. At times it is scattered around few. And so I identify those few by this scan. Bone syndrome is not. So how do you treat primary hypertension? Step one, step two. Again, I said earlier, you have mild hypertension, so-called asymptomatic hypertension, low-grade hypertension. Stage beyond stage one, below stage one, you wait and measure, be sure that it is hypertension, second measure, third time. That's why that and take the average of last two measures to diagnose primary hypertension and then exclusion of the other primary causes of hypertension. This is how secondary cause of hypertension. Two, but when you have stage 2-1 hypertension, then you have asymptomatic. You have chronic kidney disease underlying cause. You have the premature cardiovascular events. You have target organ damage. Secondary hypertension obvious. Then you cannot wait. You go for the investigating him and taking measures. When you have more severe hypertension, you have more organ damage, as acute severe elevation of BP or chronically elevated BP on 180 and systolic and more than 120, diastolic. Perhaps you cannot wait to admit and do investigations and take urgent measures. So after reaching to the safe zone, or patient was in the safe zone, you go for the non-pharmacological means of antihypertensive like dash time, dietary approach to stop hypertension. What this abbreviation tells means less sugar, less fat, and less salt and right, and less calories. There's four less. Four less is a must. So and then that means given what are the most fruits and vegetables. More excess of everything is bad. True fruit excess, excess kora jabe na. So in that way, yeah, liberal should I say, yeah, to make sure that potassium, calcium, and magnesium, yeah, adequate amount of recommended RDA are being ensured, and then appropriate weight, optimum calorie. You know this part. WHO recommends the walking, vigorous brisk walking, moderate to brisk walking for 60 minutes in a day, 3 times at least daily, minimum in a week. 3 into 60 minutes, 180 minutes. Weekly 180 minutes is minimum. You can do it in divided way. 7 days, 26 minutes in a day. Total is 26 to 7, 25 into 6 into 7. It becomes 180 minutes. So this is the recommendations. Like these are the optimum sleep, stress reductions, less screen time, And you have this is the figures like 2 millimeter, 3 millimeter reduction. I'm not going physical measures like the best drug nowadays, as I said earlier, the sinivitin ARB. First drug always should be the either of the two. And one they are not recommended to be combined. And then you have second drug, calcium channel blockers. Calcium channel, I told about but dipyridine containing, but other non-di one, the verapamil and the I think coming days will be your days will be with verapamil and diltiazem because it has antiproteinuric. This group disorder has antiproteinuric effect. Thereby, they are renoprotective, decrease the progression of CKD. Renal disease is diagnosed early, they won't go beyond. Thereby, there's a question in the exam. What are the causes? What are the measures? What are the drugs that are used that you can use for the CKD progression prevention? As inhibitor, here, CKD progression, yes. 1, 2, 1, 2, as 3, carbidopa, yes, carbidopa, and your SGLT2 one. Then, and MRI inhibitors, dual receptor blocker, and you have as you said earlier, MRI receptor blocker, dual receptor blocker, MRI receptor plus endothelin receptor blocker. You have dual receptor. It's not available perhaps in this country. Hopefully, if you use, then it will come in the market. So there are 9 or 10 measures that are essential for the progressive reduces cigarette. That's important. So
the target blood pressure in
the cigarette target, yeah, it is in the slide. Target BP in CKD is the chronic hypertension, proteinuric hypertension. Must be below 50 centile. Non-proteinuric, CKD always below 50, around 50, not above 70. Non-proteinuric, you can go for 50 to 70, around 5, 50 or back. It's nice. They have slide in this regard. So these are the choices. Proteinuric hypertension, Sanjita's question is over here. ARB and inhibitor, 30% reduction of proteinuria, either, not in combination. And other renoprotective drugs, 8 or 10, as I said earlier, in AKI, in AGN, your APHGN means for heart disease, heart failure. You have volume load issues. So give diuretics, reduce the volume load. Fusimide, 1 to 12 milligram per kg per day, IV, oral, whatever, mostly IV. So heart failure, tachycardia, you have beta hypertension, tachycardia, you have beta blockers, sympathetic discharge, and sympathetic catecholamine producing hypertension are better taken care of by the beta blocker. Hemodialysis is the best modality to treat the CKD-SRD hypertension. And you have the catecholamine issues, when their diagnosis in our situation, they perhaps better treated with the phenoxybenzamine and beta blockers. No beta blocker in heart failure, traditional teaching, you know this part, and asthma. Super selective beta blockers can be used. What this summary of this slide tells about the mechanism of action of the S inhibitor, why does it work? Angiotensin 1 to 2, you know these things. And then finally on the right side, on your left side, you have the calcium channel blocker. Why does it works? Why does it prevents? It prevents your calcium, as I said earlier, calcium dependent, calmodulin dependent channel block. Thereby it is renoprotective, reduces proteinuria, like other two, S inhibitor and ARB. On the other side, you have enough blockers. As you told earlier, good response. I got your answer, and you have a beta blocker, cardio deceleration, etc. And finally, rest. I think we talked these things. Primary hypertension, better drug, better drug, better drug. You got this. By this time, we talked these things. Renovascular hypertension, CCB, not this first one. Good one. The good boy over here, first boy is always SNITRB. But not the good boy, first boy for the primary hypertension. It is the CCB from the calcium channel blockers. And CKD, it is again. Last time I was telling this last few days, I'm telling, yeah, but this what Schaeffer and he wrote this, Wardy, Bradley, what did they wrote? They wrote, you go on giving a symmetry ARB until patient dialysis. You will benefit of the proteinuric hypertension without even proteinuria. You will benefit of the CKD progression, prevention, and even in dialysis. So do not jump to stop the symmetry ARB patient when patient has the your CKD creatinine elevation. Previous text, the previous views, 2016. I think they will be telling the Baka and then the Sylvester, they will be doing different things in their upcoming issue in this month or next month, something. So obesity related hypertension, always you use the SNOTR. They are always the first drug, except these ones, always first drug, the diabetes, hypertension, athletes, etc. So what the another question, how much you reduce the goal? You know this things in emergency hypertension. Not if you do very too fast, what will happen? Auto-regulation, cerebral, cardiac, renal, and retinal. Auto-regulation, vascular. There are 5 organ damage. One, cardiac. By far, the commonest cause of death, cardiac. 40% of the death is by heart. So I'm going to stop right within few minutes, and then if you go for faster reduction, you'll have auto-regulation. But you haven't seen a case where there's auto-regulation braking system. We saw plenty of death by dint of this. There is no movement. Sorry. We saw plenty of death by our inefficiency, inaccuracy of controlling the BP. Globally, it is the same data, less, more or less, not that different. Thereby, adequate control BP. You don't see much children who are dying of the breakage auto-regulation. You will see children who are dying because of the uncontrolled BP and organ damage, mostly heart failure. So, Sanskristo, this is traditional teaching. When a child has faster breathing, more than 25%, you think this and that, heart failure, hypertension, volume overload. Malcolm Madam used to say 20, 30 years back, the child who was given IV fluid has a faster breathing, has faster pulse, then stop bleeding. The book version is 25% increment, stop infusion, stop albumin, stop everything, blood, fluid, everything. So this is the nuisance. So it happens, in every institution, ours, and it happens. So goal is to have said a child who has chronic hypertension, primary hypertension, CKD, as Sanjay was asking, and hypertension like us, primary, your atherosclerotic, your dyslipidemic, your family history, all this and that. We genetics, so we should have safer side, below safer side. So it's how much? It's for the adult above 13 years. How much for like adult up until death? How much it is in 70, 60 diastolic, 60, 55 is no harm, and then systolic 90, 100, 95 no harm, not beyond 110, never. বলে দেখি দেখবো, it's not a place, play with the life, don't take that play. So then sublingual nifedipine we used in our early days, very high load. And that Salma is here, she knows how much albumin. Nowadays there is one mishap in the other department and anesthesia. So you use the judiciously, use the dose. Recommendation is 5 milligram, 10 milligram, 0.0 something dose is there. This calculated dose and give and see the BP until you arrange the IV fluid, IV antihypertensive. Could I make you understand? So it is recommended till date. We are not using for other reason. There was some legal issues and bring these things over here. And this is the target BP, like what this slide says, the summary of the slides. It tells about the same BP and the measures are same. I'm not going to read this thing. To brain, stroke, this and that, retina, artery, kidney, heart, what it happens, what it does, what are the same BP like. This is all the same, what we talked earlier. And then these are the mechanism medications. Bazar ki ki ache? Labetalol, your hydrogen, yeah, and this is the response of this Sanjita's question. Less than 50 centile, less than 50 centile. But below 50 you have hypertension. Then why do you worry? Why do you bother for the patient who has accelerating the cardiac damage, renal damage, and CKD progression, immediate death? So this tells. Reference every side is almost every side is reference. Yeah, AJ, American Heart Foundation. Schaeffer book. ওখান থেকে নিয়ে আমরা ওকে cross করেছি. So this is what this slide tells. First drug is RASI, SNOTRB. Second one is CCB, calcium channel blocker. Third one maybe then others combinations. You need to combine chronic hypertension, lifelong hypertension. If you do the transplant, dialysis, whatever, he will be happy, he will have continued hypertension. So you need the lifestyle modification, DASH diet, less fat, less sugar, less sweet, less salt, and your exercise, adequate, appropriate weight. You're underweight, only you go for the renal dieting, and then your lifestyle modification. Dialysis is the best modality to control BP. But there are dialysis কাজ করছেন দেখেছেন how much the antihypertensive does, how much this dialysis takes care. So it's different. Transplant patient again here it is not the ACE therapy. It is the CCB, calcium channel blockers. Here again the renal artery issue is there. Do you understand me? Renal artery narrowing, transplanted kidney may be compromised further. So no, don't use over here the acidity therapy. Here the calcium channel. Second one will be the first. So Rasi is there. It is the second choice, and others are combinations, lifestyle, everything. And the first one. And PSGN acute post-stroctural. This blast pattern is going to resolve by the course of time 1 month or so, 18 to 28 days, highest by 3 months, isn't it? Acute post-stroctural GN. They are used diuretics, fusimide, because mechanism of retention over here is the overload. So overload is been taken with renal function is all right. You go for giving the fusimide up to 12 milligram, depending upon your patient. But give every infusion and stay beside patient. See whether she is getting or he is getting hypertension, and you push faster the fusimide. There may be hypersensitive otitis media. So thereby make sure that you haven't pushed for 5 to 20 minutes. 10 minutes average is nice, and always IV. And your vasculitis again, RAS activation, so they are anti-RASi. And hemolytic uremic syndrome here perhaps the CCB again, the second boy. So I think I have finished the talk. This is what all children appeal to measure their BP. We haven't done fair, we haven't done justice to these children in our time, if I say, and secondary causes to identify and to be treated. Healthy diet, healthy lifestyle. Thank you very much. Do I hand over the Zubaida Romana?
Thank you, sir, for a brilliant presentation and very interactive also. So is there any question from online? There is no question. In-house, any questions? No question. So sir described all the things.
স্যার একটা কোশ্চেন ছিল স্যার
Sure.
স্যার আমি সৌরভ বলছিলাম ডাক্তার সৌরভ
আপনাকে বোঝা দেখা যাচ্ছে।
স্যার আমার দুইটা কোশ্চেন স্যার এজিএন এর রোগী আমরা তো স্যার সবসময় কমনলি পাই ওয়ার্ডে এজিএন এর যখন হাইপারটেনশন থাকবে আমরা জানি 60 to 80% মে সাফার ফ্রম হাইপারটেনশন ইন এজিএন পেশেন্ট তো এজিএন এর পেশেন্ট আমরা জন্য অ্যান্টি হাইপারটেনসিভ আমরা শুরু করব এটা কিভাবে এটা গ্রাজুয়ালি ট্যাপারিং করব বা গ্রাজুয়ালি অফ করব এটা মানে প্রোটোকলটা কি এটা এক নাম্বার কোশ্চেন আর দ্বিতীয় নাম্বার কোশ্চেন হচ্ছে স্যার মানে আপনাদের এক্সপেরিয়েন্স কি আইভি অ্যান্টি হাইপারটেনসিভ যখন বিএসসি মতো ইউজ করেন স্যার তখন এই ইউজ করার সময় কোনো হ্যাজার্ড বা কোনো প্রিকশন আপনারা নেন কিনা ইন কেস অফ আইভি অ্যান্টি হাইপারটেনসিভ এই দুটো প্রশ্ন স্যার
থ্যাংক ইউ সৌরভ, আমি আপনাকে বুঝেছি। সো সাপোজ আপনার একটা বাচ্চা 5 থেকে 15 বছর, সাপোজ একটা 8 বছরের একটা বাচ্চা যার ওজন 24 কেজি অথবা 30 কেজি, এরকম 30 into 2 কত হলো? 60। ঠিক আছে সৌরভ,
জি স্যার।
do you hear me?
জি স্যার জি স্যার
সৌরভ আমাকে শুনতে পাচ্ছেন?
শুনতে পাচ্ছি স্যার
সো 30 কেজি, সাপোজ ওর 25 কেজি ওজন, 25 into 2 মিলিগ্রাম কত হলো? 50 মিলিগ্রাম।
50
আমি ওকে প্রথম শর্টে ওর বিপি আছে সাপোজ হলো কত 130, 35 থেকে 100 একটা ফিগার আছে। আমি ওকে এই 2 অ্যাম্পুল ল্যাসিস দিব, স্লোলি 10 মিনিট ধরে দিব, পাশে বসে থাকবো, দেখবো যে কোনো দেন তার বিপিটা মাপবো, 10 মিনিট পর বিপিটা মাপবো, দেখবো এটা কি কত হলো, এটা কি কমে গেল নাকি এখন একটু বেশি আছে। বেশি থাকলে আমি আধা ঘন্টা 1 ঘন্টা পর আবার আসবো, চেক করবো, দেন আই উইল মেজার বিপি অ্যাগেন, I will infuse another 2 ml, 2 ampoule of whatever. Total আমি সারাদিন এইভাবে করে টুকটুক করে ওর পিছনে আমি লেগে থাকবো। On that day I will not leave the patient. I will be after him or her until BP is reaches the safe zone. Here I will keep a little bit on the upper side. Suppose ওর জন্য আমরা 110, 15 অ্যালাউ করবো, ওদিকে 100 যে ফিগারটা ওইটাকে আমি 70, 80 পর্যন্ত টার্গেট করবো। But I will go slow. And একবার দিব, বসবো, আবার আসবো, দেখবো, আবার আসবো, দেখবো, এইভাবে করতে করতে at the end of my এফোর্ট আমি তাকে 115 এরকম একটা ফিগার, 120-এর নিচে নিয়ে আসবো, 115, 10 এরকম একটা ফিগার নিয়ে এসে আমি ওইখানে রাখবো। too much overzealous exercise of hypertension
মোবাইলটা
reduction.
বন্ধ করুন।
Here you have renal hyperperfusion, renal hyperperfusion, and then your ATN and AKI. So এটা আমি করতে দিব না এই এপিজিএন কেসগুলিকে আমি অফিসে লেগে থাকবো ওই দিন একদিন পরের দিনের মাথায় আমার বিপি হয়ে যাবে নর্মাল, ওর যেটা হয় 110 কিংবা 115, আর আপার নর্মাল 75 and 95, around 75 or so. সেখানে systolic 100/85, 75 এর ফিগার আমি আসবো, আমি লেগে থাকবো আনটিল হি সেটেল বাই নেক্সট ফিউ ডেজ। আমাদের এক্সপিরিয়েন্স এখানে খুব হ্যাপি। আমরা আমাদের ইউনিটে কখনোই গত 10-15 বছর ধরে কখনোই আমরা অন্য হ্যাপাটাইটিস দিতে চেষ্টা করি, এটা দিয়ে 12 মিলিগ্রাম অ্যাক্সিড করে গেলে অন্য কিছু দিতে হলে আমি এটা দিই। আমাদের কোনো অ্যাক্সিডেন্ট হয় রেকর্ড হয়, খারাপ কিছু হয় নাই। আমাদের কেস রিপোর্ট আছে এখান থেকে ইরানের জানালো পিডিয়াট্রিক নেফ্রোলজিতে মাসুম মোকা আমাদের বন্ধু, ওনার কাছে আমরা লিখেছি পেশেন্ট শকে চলে গেছে, ওকে আমরা রিভাইজ করেছি এইভাবে। আর কোনো কোয়েরি সৌরভ, ইউ গট মি?
না স্যার, থ্যাংক ইউ স্যার। আপনার স্যার মানে হয়তো স্যার আপনি রিটায়ারমেন্টে যাচ্ছেন স্যার, আপনাকে মানে রিটায়ারমেন্টে যাওয়ার আগে স্যার আপনাকে যথেষ্ট আপনি স্যার আমাদেরকে হেল্প করছেন। আপনাকে একটা শর্টলি আপনাকে স্যার আমি আপনার মানে ভালো মানে ভবিষ্যৎ এবং আপনার ফ্যামিলি, আপনার সুস্বাস্থ্য সবার জন্য মানে শুভকামনা থাকলো স্যার।
Thank you, Saurabh. Thank you very much. Yeah, now I hand over them,
স্যার
Yeah, please বলেন। হ্যাঁ, শর্মিষ্ঠা শোনা যাচ্ছে, আপনাকে দেখা যাচ্ছে।
স্যার
হ্যাঁ বলেন।
স্যার ওই যে আমি একটু বলতে চাচ্ছিলাম, আমার একটা পেশেন্ট, আমার আত্মীয়, ওর বয়স 14 বছর।
হ্যাঁ
ওর ব্লাড প্রেশার হচ্ছে দুটো অ্যান্টিহাইপারটেনসিভ খায় স্যার। এখন তার সে এখন আছে, তার ব্লাড প্রেশার 125/80। আপনার কন্টিনিউং টু অ্যান্টিহাইপারটেনসিভ স্যার, বিসোপ্রোলোল সে পাচ্ছে। বিসোপ্রোলোল কি 14 বছর বয়সে কি এটা দেওয়া
যাবে
মানে?
ওকে 5 মিলিগ্রাম করে দুবার দেন। 14 বছর বয়স তো,
জি স্যার।
40 কেজি 30 কেজি ওজন।
এখন স্যার যেহেতু প্রথমে মনে হয় স্যার চলতেছিল, ক্যালসিয়াম চ্যানেল ব্লকার চলছিল, ওটাতে খেয়েও স্যার কমছিল না। সে 2-3 বছর ধরে এটা খাচ্ছে, তারপর কমছিল না বলে স্যার বিস্কুট করা হয়েছে। স্যার কজ খুঁজে পাওয়া যায় না, কোনো কজ খুঁজে
মোটা নাকি না? ওজন কত? 14 বছর ওজন বলেন স্যার।
অনেক বেশি স্যার, 65
তাহলে
65
ওটা বোঝা গেছে প্রাইমারি হাইপারটেনশন। এই বয়সে এগুলো